So welcome everybody. My name is Nari McMahon and I am the Director of CRI UK, Centre for Right Relationship here in the UK. We are the ORSC training providers on behalf of CRI Global. I am also an ORSC certified practitioner and also lead the training in ORSC. I'm here with my colleague, also an ORSC practitioner, Dr. Daljit Hothi. She's the consultant pediatric nephrologist and clinical lead of home, I can never say this, hemodialysis at Great Ormond Street Hospital. But you're also head of the leadership team there, aren't you? Wellbeing.
So I am the Associate Medical Director for Wellbeing, Leadership and Improvement. So yeah, I'm responsible for creating a really robust offering for leadership and well-being in the organisation. So really exciting, actually.
So today, it's funny that it's exciting because today the topic is, what does it mean to be in relationship in the healthcare sector? We've discussed, you and I, a number of times that healthcare workers are in relationship with so many different, complicated relationship with different people. We've got the patients, we've got your colleagues, you've got the practice or the hospital, then we've got the wider context of the NHS, pharmaceutical companies, and obviously the wider community. So we'll be looking at what it means to be in relationship in the healthcare sector and how the healthcare practitioners can consciously approach their complex range of relationships. I wonder if we should, before we start talking about it, should we just define relationship systems, what we mean by what we mean in ORSC? We mean just the classic definition or the textbook definition is a group of interdependent people with a common focus or identity. And the key words here are that they're interdependent and have a common focus or identity. So Dal, I'm going to call you Dal. That's what we've agreed.
Perfect.
What does it mean to you to be in relationship?
So what's it be in relationship? For me, it's a space between two people or a group of people, the space created by two individuals, a group of people. I don't think I really understood what in relationship meant until I'd done my ORSC training. So for me, it's like a unique energy, an essence, a unique set of aspirations and fears, characterized by a unique set of sort of, I suppose, behaviors and actions. So a relationship is unique, it's wonderful, it's new, it's different, created by the people in that relationship. I like using metaphors, so I'm going to use a metaphor for what it means like for me.
Yeah.
So when I'm in relationship with somebody, I am having I guess I'm creating something. It's akin to unconsciously often creating a living, breathing entity with a personality, likes, dislikes, habits and needs. And so that's what a relationship is, or to be in relationship is. But often we don't think about it. It's very unconscious. And I don't think we realise it's there until trouble hits us. And then we start thinking about the relationship. I seldom viewed it as a dynamic entity. I seldom viewed it as something that connects us and that sense of interdependency that you talked about. Sometimes we can be very critical of relationships, saying, blaming others on the relationship or how our relationship is poor. It's that person's fault. Or it's never my fault. It's never about how we are coming together in that space. So I think being in relationship is this beautiful space between two individuals or a group of people.
It is, isn't it? The minute you tap into it, you all of a sudden understand the responsibility you have in creating and maintaining that relationship. That if you withdraw, if you don't participate, if you sometimes don't change the roles that you occupy, or if you're not conscious about it, then the relationship does wither away or gets to the point where we're disappointed with it. So I want to ask you, what do you feel is unique about relationships within the healthcare system compared to, say, other industries, or what's unique about it?
It's so complex, isn't it? I think the intensity of relationships in healthcare systems, and also it's quite paradoxical in nature sometimes. It's a relationship that we wish we'd never have to experience. And when we have to experience a relationship with a healthcare professional, it's not out of choice. So with that comes a lot of, I suppose, emotions. It's forced upon us. It's when we're most vulnerable. So there's that element of that relationship that's incredibly vulnerable. And it, without any permission, draws us on a very emotional level as well as a sort of cognitive level. So the relationship can be very intense and multi-layered. I think the healthcare industry at its core is about the provision of care. We like to treat people, we like to cure people, we like to provide answers and solutions. But there's that paradoxical side of our relationship with medicine, and that's an element we like to bury. And that's really that medicine can also be about death, disappointment, and disability. And that's true for both the patients that we treat, but also the providers that deliver that care. So that relationship makes it really complicated. Its strength comes from the fact that it's delivered by humans, and humans can be adaptive, responsive, empathetic, compassionate, kind, but also that relationship is the weakest because of humans, you know. Humans make mistakes. Humans have to make decisions based on judgment rather than facts. Humans have limited resources and abilities, and humans are humans. And so, you know, there's a real sort of truth to that sometimes is not noticed or acknowledged. And I think the relationship is traditional at times, like, you know, full of history, and then it's cutting edge. So it's about endless hope, and it's about dealing with the harsh reality of unforgiving defeat. You know, we don't like to be defeated. It's a continuum of emotions, and the extremes adds to the intensity of that relationship. And I think it's a relationship as much about the heart as it is the mind. So that's what makes the relationships in healthcare incredibly challenging at times, but also gives us so much and makes us want to continue in the healthcare setting.
Yeah, I must say, I love the idea that you are right. It is where we go when we don't want to go. We're terrified of going, but then when we're most vulnerable, that's the only relationship we want. We want to be cared for, and it's the hope, and then the hope is taken away, or the hope is reality. Yeah. It's all these things, and we're humans.
It's like a kaleidoscope. You just can't explain what one relationship is going to be from one day to the next, 1 minute from the next, actually.
Yeah. So do you think that having different personas dealing with different relationships help? Like, as a doctor, are you kind of navigating what kind of persona you should have, or who? Is it the traditional doctor that's coming, or is it the cutting edge doctor?
I don't think we get an opportunity to explore that, actually. I don't think we sometimes give ourselves the space to really know what that means. What does our profession mean? What does my label mean for me today? Sometimes we just go into automated mode. I could say that for now in COVID, a lot of us are functioning at automated level. You know, we don't really want time to think, because if we think, we may try to make sense of something and we may not like what we're making sense of. So I think that complexity is great, but it's also very difficult. And I think we sometimes need to draw attention to that complexity. What are the different natures of those relationships? What are the different levels of those relationships? What does that mean for you? What does that mean for others? And I don't know if we actually give people the chance to consider that, appreciate that, think about that.
How are you trained to approach your different relationships at work? Were you trained?
Oh, no. So, I mean, that was, I think that's quite uncanny. So I wasn't trained on relationships. It just evolved organically. And I think the most training I had was through ORS. I think the training in relationships comes from need. Our exposures, our experiences, what we consider important at the time. And what's important changes as our career progresses. So, you know, obviously, the relationship that we observe, the relationship that we notice is different at different stages of our career. So I guess taking myself through my journey when I was at med school, my focus was on medicine and science, and it was a really cognitive relationship. So all I focused on was the learning of the art of medicine. I think then as I started to meet patients, both as a junior, as prior to being a junior doctor, so during my training, and then as a junior doctor, I really started to appreciate and witness the different emotional responses people had to their diseases, their treatments, to each other, and to me as a healthcare professional. But at the time, I really didn't make much of it. it wasn't my focus. I didn't appreciate it. I didn't notice. I wasn't curious about it. And I don't think I saw myself as an active partner in what was manifesting. It was just as it is reality. As a junior doctor, I think the relationship I hold dearest to me is the relationship with my fellow junior doctors. We're in this club, we're in this tribe together, and we felt really connected. And as we sort of traversed through this journey of training, that sense of belonging and relationship was really strong. And I think the relationships with our senior consultants, our nursing colleagues, and the other healthcare professionals that we worked with, that was something that I could say I was in relationship with. I understood that relationship because I could see that I was contributing to that. It was evolving and changing, and I felt that I was part of that, but not really of my patients, interestingly. What I noticed of my patients was being really conscious that I got my diagnosis correct, I got the right treatment for them. We talked about learning, but learning was really focused on deficit. What did we do wrong? What could we do differently next time? And the emotions were there, but they weren't really allowed to surface for long. I either swept them under the carpet, we ignored them, or just saw it as part of our job and we accepted it. But we really didn't dwell on them. It was only when I became a consultant and I suddenly had this list of patients that I was the named consultant. I was responsible for their care. And I saw them for weeks, months, years. So actually having that longevity of relationship, if you like, that I really started to understand what it was to be in relationship with my patients. But that was really probably the first time I really noticed it, and how my approach and their approach really affected the working relationship between us. So I think that was only really apparent to me at that point. And then over the last few years, as I've taken on the different roles, labels, as you say, management, learning development, coaching, all these different labels, I've started to see different elements of the NHS, different elements of the organisation. And I'm starting to appreciate the different relationships I have with the NHS, with the organisation, and different elements of the organisation. So yeah, I think I've started to see that system relationship now, but I probably didn't see it until I was starting to look wider than my relationship with my patient and myself.
But what drew you to sort of look at the coaching and leadership? Was it the role that required you, or was there some drawing?
Interesting. I think I certainly, when I went into management, I wanted to go to management, so I want to have an impact at I suppose at a larger level. I didn't just want to have an impact on one patient. I wanted to be able to have an impact on a number of patients. So I wanted to intervene and make positive changes for our patients' lives. But as I was in an operational role, there's other elements of operational that steered me away from care in some ways, because the focus can be on finances and safety and those other things. And I felt that my energy levels are starting to deplete. I just wasn't happy. I could do the job, but I wasn't happy. But what I was happy with was when I was nurturing or supporting people through their own journey, when I was supporting somebody in their career progression, when I was supporting somebody's well-being, when I was effectively coaching but didn't realise I was coaching. And that's what made me sort of go down the coaching route.
Okay. I just want to notice, just want to reflect back when you were speaking about the young doctors, the young doctor that you were, and that you were all in this together. The joy in your face was
it was great. Yeah, you felt like you were part of this group. It was like, we all like to be part of a group, don't we?
We do. So how long have you been at Great Ormond Street Hospital?
I was there as a junior doctor. Then I travelled the country and worked in different hospitals. That was our life as a junior doctor then. I even went to Canada for 2 years. I worked in Toronto, and then did some research at Great Ormond Street in Toronto, and then became a consultant 10, 11 years ago. Right. So yeah, so it's been a journey.
Yeah. And did you notice different kinds of relationships, or I suppose the culture, which is the relationship? Did you notice them as you were going through different different hospitals. I mean, I know that you already mentioned that there was a role, the role gave you a bigger focus on what relationship is, but can you recall that they were different? Was there different types of relationships?
Oh, definitely. I mean, I think just that interesting transition from adult medicine to pediatric medicine. So in adults, we focus on the adult, the patient in front of you. In pediatrics, we focus on the patient and the family. The relationship is suddenly very different. I think if you're in an acute setting where you may see a patient once or for 24, 48 hours is very different to when you're working in chronic care and you may be meeting patients for their lifetime or for years and years on end. So again, that relationship is quite different. Surgical versus medical settings are very different. Surgeons are there to treat, and they can often be a very discrete point in somebody's life, where the medical doctors may be there for much longer, treating the sort of the diseases behind that patient's sort of requirement for healthcare. So that can be very different. I think also generational. I'm going to say generational because I'm not so old now. So actually, I think when I started as a junior doctor, we had a very paternal role as doctors. We were the experts, and we knew what was right, what was wrong, what was the best course of action for our patients, and we directed it, often with very little consultation with the patients. Now it's a very different ethos. So patients are partners in their treatment and their care. So actually it's a very different relationship. So we're partners rather than having this paternal role. Yeah. I think as healthcare has evolved, duty of candor, being candid and being open and honest about when mistakes occurring in hospital, that vulnerability now is not just with the patient, but it's with the professionals as well. And that changes the relationship. This learning culture is also something that maybe our patients don't want to see. They don't want to see that their doctors are learning. They should have the answers, and they almost want the complete package rather than the inexperienced juniors who may be treating them. Well-being is so important now. So well-being of staff is now seen to be as important as the well-being of our patients. But that's only in recent times, the last few years. But that is having an impact on the relationship we have with the NHS, we have with our organisations. And digital, the lovely digital technology. We're on a Zoom call, but digital is invading healthcare. And that's going to change the way relationships will manifest, evolve, develop. That's definitely going to change relationships in the NHS and in healthcare.
It sounds like in all of them, you know, there's an active consciousness around the fact that the context of our world is changing, the context of what our patients want is changing, because, you know, they pretty much know what their symptoms are before they come into the clinic just to get verification. And then they go off and check out lots of things and panic or not panic or find somebody else. So you are right, the context of the world and medicine is changing, and our relationships internally are changing as well. I have a few more questions, but I am really interested in finding out, now that it's Wellbeing Week, especially because of the COVID-19, is there anything special that you know, you're bringing to are doctors being taken into account for that, or is it just the public that's involved in this week of awareness?
Oh, definitely a lot of work in the doctors and staff across the organisation. So with this COVID, we had a huge commitment to actually really focus on the wellbeing of our staff as well as our patients. So we've had an active series of interventions to ensure that staff have wellbeing practitioners at hand that they can contact and reach out to. We've actively sought out where there may be high-risk groups and how we can help them, supporting our managers so that they're having wellbeing conversations and more psychologically savvy, if you like, conversations with their staff, and actually sort of really trying to change the tone of their conversations with their staff and how they approach that sort of conversation, that sort of listening rather than judgment, and trying to understand the space that their staff may be. It may be irrational, but that's the space they're in. And in this time of COVID, normalization is incredibly important. So I think my horse training has been ever so important this time. I mean, sitting in the fire, normalization, all these things are there at the moment. But it's raised the profile of well-being. It's fascinating. And I've been knocking on the door about well-being for a while, but actually people want to listen and people are saying, let's do it. It's a shame that it had to be something like COVID that raised the profile, but now we've raised the profile, we do not want to let it go, and we will carry on pushing ahead.
Oh, that's wonderful. I mean, that is the whole thing around systems, isn't it? Once it sees itself and knows that it's got an issue for whatever reason, it can't go back because it's already seen itself.
Yeah.
So can I just ask, what changes would you like to see to how practitioners are trained to approach their relationships with patients, or, you know, with patients? Let's do the patients first.
I think the training that we provide for, I'll say junior doctors, because I guess that's a space that I'm more familiar with, but we could probably extend this conversation to nurses and other sort of clinical staff. There needs to be a more holistic approach to training and learning. At the moment, the focus seems to be a lot on our clinical expertise, our sort of, I guess, our trade, which is medicine. But we also now need to help and support and nurture how we support and encourage our clinical staff to understand the emotional and the mental, as well as the cognitive experiences they're having every single day. So we really start to see that people are really starting to think about the emotional well-being of staff and the emotional well-being of patients. And I think they haven't quite made the transition from emotional well-being to relationship. And I think the My Name Is campaign was really about perhaps creating that psychological safety. But I see that My Name Is a really different thing now. And I think it's a first commitment to building a relationship with our patient. We are saying we want to be in relationship with you. So let's try to have an equal balance. My name is, what's your name? And with that, there's a commitment to relationship. And I don't think that's how it was introduced, but I think that's a really huge step in trying to get people to understand who is that patient sitting in front of you. I think things like Schwartz rounds, debriefs, which are starting to explore the emotional response to medicine, is starting to occur, but I think they could be extended further. So I don't want people just to reflect on the emotional response to a case, but perhaps get doctors and nurses to think about, what's it like to be in relationship with one patient versus another? How are you coming to that relationship? What's easy for you? What's not so easy for you? And start to recognize that there's two people involved in that experience, and two people are active in that. So that's that relationship. So what are you doing to contribute to that relationship, as well as what's the patient doing? And really getting people to sort of try to understand how relationships are different because of the two people in that space, not just one person is different. So I often say to colleagues, my relationship with my sister is different to my relationship with my brother or my mum or my husband. Now I'm the same person, but that relationship is very different. And I think doctors and nurses, we really want to support and train them to start viewing things differently in that. When they are having those interactions with patients, it's not just an interaction, it's the possibility of a relationship that started to form. And I'd like them to think more about relationship rather than interaction or an episode of care, which is actually a very cognitive way of looking at it.
I mean, just to pause, I mean, you're really moving away from the transactional aspect of it to being more conscious and intentional about how you are formulating that relationship. Even what you just said, you know, Dal, when you said, my name is Dal, what's yours? It's an invitation to come closer to you. And, you know, I'm not even your patient. And just even that statement has, you know, I noticed myself physically coming closer to you. It's a funny thing, isn't it?
Yeah.
And I love the way that you've woven in all these very complicated concepts around, you know, being aware that not all relationships are going to be the same, being aware that you also have cognitive biases or, you know, preferences, but how do you still stay in relationship and even be curious about some of your preferences, and how can you in that relationship expand your own preferences?
Absolutely. And I think what's really interesting for me is that the curiosity about self is something we talk a lot about in leadership, you know, self-awareness, self-management. But it'd be really nice to make that transition to curiosity about relationship. And I think that system thinking, that we're interconnected. And so in that interconnection, what I do is going to have an impact. Whether I consciously know it or don't know it, it is going to have an impact. And I think if we view it like that, we may just be a little bit more conscious and intentional about what we do.
Okay, so we've got a few more minutes. So what changes would you like to see to how healthcare professionals are trained to relate to each other and the wider healthcare system? You kind of answered that question, but is there something else that we haven't looked at? Is there?
I guess for me, there's something about recognition of being comfortable with the uncomfortable. You know, again, I'm going to use Orr's terminology, sitting in the fire. So we don't have to label something good or bad. A relationship isn't good or bad. A relationship has lots of different facets, and it's very exciting, interesting, curious to think about all those different facets. So I think there's something about being comfortable with the uncomfortable. Let us start doing that. I think the other thing, medicine is hard. And how do we train and support our staff to understand and appreciate the disappointment we might feel at times, the adversity that we may come across, how stressful it might be, the uncertainty about medicine. So, you know, if we stay at the very cognitive level, we really are just going to miss vital parts of the relationship that could really take us to a very different level and a different understanding of what we're doing. Yeah. So I think there's something around really appreciating and acknowledging those different elements of our profession and healthcare. Valuing, as I said, that human connection, that interconnection. We're in a system, a number of systems, you know, we're not an island. I think I may not realize I have lots of interconnections of different people in the organization, but I do. If I sat down and thought about it, there's lots of people. But I don't really think about it. I don't give myself the space to think about it. And I don't really give somebody else the courtesy of thinking how I am contributing to their life and how I might be impacting their life. So some compassion around that. What impact am I having on others, consciously or unconsciously? And I think it's really important we understand that system thinking, because that's happening. And I think the other thing that we're perhaps not doing and we should do is the face of the NHS or the face of healthcare is changing. You know, our professions are changing. So what it's like to be a doctor now is going to be different in 5-10 years time when we're so digitally heavy. So I think we need to start having some honest conversations to allow our junior sort of clinical staff, doctors, nurses, to sort of really understand what their relationship with their healthcare sector is, or with their NHS is, or what their organisation is. Because that's constantly evolving and changing. If we don't give them space to think about how that may be impacting them, or how that may be good for them and not so good for them, I think we may actually contribute to their lack of wellness, and we will lose good people who actually can contribute to different elements of the NHS and healthcare. So I think we just need to be broader at a more macro level of how, by thinking about relationships, we could probably change the way the NHS and healthcare looks in the future, and probably make ourselves happier, and I think make life more real.
Yeah, it almost sounds like a new relationship with stress and tension, and maybe, as you said, that needs to shift a little bit. But I'm also loving what you're alluding to, because we are going to be speaking, we're going to be running this series of webinars or podcasts, and inviting first-year medical students to speak to you on the next occasion. And I love that we've got this segue into, you know, the digital world is going to be impacting medicine, is impacting medicine, will impact more. And just think what happened because of COVID-19. Most of them couldn't finish their last semester, and they're doing that virtually. How are they maintaining relationships virtually? How are they keeping themselves well? And what is their relationship to medicine now that we've gone to the virtual platform? It'd be very, you know, we'll take this up with them. It's a thing, like when you were speaking, I was, from, again, Orr's terminology, thinking about the 3 levels of reality, and you know, how when you're working so hard, you become so consensus reality because you've got to do this and that. But, you know, where do you allow the dreaming to come into? Where do you reconnect to the essence of what made you decide to do medicine in the first place? Because ultimately you did that because you want to improve the quality of human existence, human life, and the way we are in relationship.
And so, relationships change, they're dynamic. So it feels really daft that we are allowing it to be an absolute, you know, 1 point event. It's not. The relationship with our profession, the relationship is changing all the time. And I think it's really important for junior doctors to realize that. And actually it's okay when they start to have those questions, doubts, or different experiences of healthcare, of medicine, because that's reality. Sitting in the fire is incredibly important, recognizing that, embracing and stepping into it, but being curious about it is really important.
So Sitting in the Fire is a concept designed by Arnie Mindell. If you're interested, there'll be a link following this webcast. But it is the concept of being able to stay in the fire so that you can have those deep dialogues. And it is one of the foundations of Orr's principles. Dal, thank you so much for your time.
You're really most welcome.
Love this moment, and always enjoyed having you. And I look forward to the next one.
Perfect. Thank you so much.